Thank you. It's a real pleasure to be with you today. And I'm going to give you a brief overview of an approach to clinical training and practice that I and my collaborators call structural competency. It's an approach that goes beyond cultural competency to highlight structural racism and the institutional and policy drivers of health inequalities. Although the language of structural competency is relatively new, Jonathan Metzl and I began formulating it in a 2014 article. It's based on old ideas. My first encounter with structural competency was coming of age in the 1980s to 90s, really at the height of AIDS activism. Groups like ACT UP successfully partnered community activists with clinicians to dramatically redefine medical research and practice. Their actions led people with lived experience of HIV to serve on state and federal funding and research bodies, including at the NIH. They led to a rethinking of addiction interventions from criminalization and abstinence toward harm reduction. They put health education in the hands of lay people and peers who invented safer sex parties and ways to make HIV prevention attractive and empowering. But more than a century before that, founder of modern pathology and public health principles, Rudolf Virchow, identified the connection between medicine and social inequalities through his study of the German typhus epidemic and living conditions of low-wage workers. And then also the 1960s birthed a series of social medicine interventions from unemployed and starving African-American agricultural workers in Mississippi that collaborated with Dr. H. Jack Geiger and colleagues to found the federally funded community health centers that we know today as FQHCs, or federally qualified health centers, all the way to the Black Panther Party's free clinics, to the occupation of Lincoln Hospital in the Bronx by the largely Puerto Rican Young Lords Party, who used hospital vans to do community-based TB screening and provided holistic addiction treatment, including acupuncture. But somehow, by the 1990s, when a number of national reports on growing inequalities made national press, these inspiring interventions on structural racism had been forgotten in favor of the idea that the beliefs and behaviors of individuals from marginalized racial ethnic groups were to blame. Cultural competency ended up reinforcing the idea that people lived and died in static cultural bubbles, taking the focus away from the myriad institutional and policy drivers of racial ethnic differences in health outcomes. And it certainly left out the surging economic and political influence of pharmaceutical and biotech industries, for whom it was convenient to channel healthcare funding away from social intervention and toward patented products for individual purchase. So we're now moving toward a language of social determinants of health in medical schools and places where that term had not been used before. And I think the same is true for structural racism, particularly since June of 2020. But what we need to do is to broaden the lens beyond social determinants of health even further to the structural drivers of social determinants of health. For example, racially segregating housing policies are the driver of widespread homelessness, which strongly links to health outcomes. The same for discriminatory law enforcement and sentencing, which lead to racially unequal legal involvement with serious health consequences. It's easiest to see the impact of structural drivers at the population level. So this 2014 study by the National Academy of Medicine had the soundbite that the US spends the most on healthcare of all industrialized nations and has the poorest health outcomes. It pointed to the US policies driving social and economic conditions, toxic physical environments, and lack of universal health coverage as reasons for that inequality. Another international study showed a linear relationship between measures of social inequality and the prevalence of chronic physical and mental disorders. So with regard to racism in particular, international comparison studies of, for example, hypertension in Black Americans have highlighted racist environments as a toxin, with Blacks in West Africa showing lower levels of hypertension than whites in the US, let alone US Blacks, in contradiction to US clinicians who are looking for an African gene, quote unquote, for hypertension. And myriad forms of institutional racism have been directly linked to health inequalities, including mass incarceration and racial segregation. So let's focus on racial segregation. That's the bank lending practice that denied mortgage and small business lending to Black, brown, and immigrant neighborhoods over the past century, and has enduring effects since home ownership is the primary source of wealth among Americans, and neighborhoods without access to home ownership see progressive deterioration in wealth and ability to finance education and medical bills, with serious consequences. Death by preventable diseases like diabetes, cardiovascular disease, asthma, and HIV. So why this moment to roll out the language of structural competency? We know the terrible statistics on the poor return on investment that we get for what we pay for healthcare in this country. And clinicians know that it's due to social and systemic factors, but they don't know what to do about that. They are therefore dropping out of clinical practice in record numbers. The momentum of prior health reform efforts towards rewarding improvements in population health that clinics achieve may still be with us. And trainees are out in front demanding action on structural racism in healthcare. One example of that is White Coats for Black Lives, and also student-led movements to create sanctuary clinics for undocumented immigrants. So what are the essential components of structural competency? And just a moment on what structure is and what competency is and structural competency. So structure highlights the need to shift the focus of our work as clinical practitioners above the focus of the level of the individual to institutions, clinical, educational, correctional, etc., to communities and to policies that determine health. And then competency indicates the expanded scope of clinical intervention and responsibility that we would need to have in order to address health problems at those levels, above the level of the individuals. And that's critical for us as clinical practitioners because we have symbolic and social and cultural capital to bear, meaning when we talk about an issue as a health problem, we tend to get a certain kind of audience, including from policymakers, that lay people don't have. So that's one reason that we as clinical practitioners should be acting at these structural levels. But back to the question of what are the essential components? Okay, here we are. The essential components of structural competency. First, recognizing structures that shape clinical interactions. So we can't do much about structural drivers of health until we understand and can see how they are influencing our patients' health. Second, we need to take patient presentations and retool them away from a cultural interpretation to structural interpretation. How are structural drivers at play as opposed to individual beliefs and behaviors of patients, cultural beliefs and behaviors. And then third, this is where I spend a lot of my time these days, observing and practicing structural intervention. So we as clinical practitioners, we are practitioners. We want to do things rather than sit around and philosophize. And we see one, do one, teach one. We need many more opportunities for that in clinical education, to see one, do one, teach one in terms of structural intervention. And then lastly, but not least, we need to develop structural humility on two counts. One is we as clinical practitioners are not all-knowing, and we don't have the full skill set that's necessary for structural intervention. We don't know, for example, how to do community organizing. We don't often know very much about policies and how they're made, but we can collaborate with people who do. And then the second note about humility is that it really takes time to achieve structural change. So it's not a matter of days, weeks, or even months. It's really a matter of years, and we have to have that time frame in mind. So here are just a couple of images to signal the structural competency network that I and colleagues are forming across the country. And we're attempting, this is a website that I invite you to visit. We're attempting to compile and disseminate training materials, articles, and webinars on the components of structural competency that I just showed you. And we've published a book, just one step in the direction of sharing case examples of how clinical practitioners and educators around the country have put structural competency into action concretely. And these cases are organized in terms of 4 levels of structural intervention that I've identified. The first level is the low-hanging fruit of what you can do inside the clinic itself. Examples include screening tools for social needs that you can use during patient evaluations, which my colleagues at UCSF have shown in their studies to increase the number of referrals for services such as legal aid, food, and housing assistance. So just putting questions about social needs into an electronic medical record that prompts a practitioner when they're doing a patient assessment increases referrals for social needs. Other examples include partnering clinicians with pro bono or student lawyers and medical legal partnerships that can pursue, for example, negligent landlords for lead poisoning, or schools or employers that violate the Americans with Disabilities Act with their patients. Other examples include making peer navigators and community health workers salaried members of clinical teams. The second level of structural intervention is clinicians who develop partnerships with community organizations. And this image illustrates the work of my colleagues to bring, for example, addiction and mental health services to Black and Latinx churches, as well as Native American healing circles. At NYU, I've been pairing psychiatry residents with a peer navigator to visit community organizations in Harlem that surround a Harlem clinic that they rotate through. So these are organizations in the community that can support the recovery of patients in the clinic. And then residents map these organizations as treatment resources on an interactive digital platform for clinical teams to use in treatment planning. The third level of structural intervention is collaboration with non-health sectors such as schools, law enforcement, and urban planning. So this is an image of my mentor and friend, Mindy Fullilove, who's done extensive research on the health impact of racial integration of US cities through deliberate urban planning and architecture that joins together previously segregated neighborhoods and through common space. The fourth and final level of structural intervention is training clinicians as policy advocates so that they can use their authoritative voices on health matters to reframe harmful policies, such as drug laws feeding mass incarceration, as a health issue. An example of an organization that's doing this is the New York City-based From Punishment to Public Health. It's a collaborative of clinicians with disenchanted law enforcement officials and formerly incarcerated advocates to lobby for diversion of people arrested for low-level crimes from carceral systems to mental health and addiction treatment programs. And finally, structural competency could not be better suited for the current moment of the collision of racial inequalities in COVID testing, treatment, and outcomes, with protests against racial violence of policing and incarceration. In a webinar series that I organized this spring, we heard from clinicians, community leaders, and social scientists about COVID-related structural competency efforts across the US. And I'll go back to this slide from that webinar series. So clinicians are partnering with leaders in Black, Latinx, and Indigenous communities to develop trusted messaging about COVID safety precautions and to secure or manufacture and distribute personal protective equipment, as well as supplies for medical and basic needs. Clinicians are joining community leaders to lobby for adequate housing for state and federal policies that release people incarcerated on nonviolent criminal charges, as well as free care and legal protection for undocumented immigrants who would otherwise avoid healthcare facilities and thereby avoid COVID testing and treatment, as well as more equitable distribution of federal, state, and resources for healthcare and economic relief. So you can see recordings of this webinar series at structuralcompetency.org under the announcements tab. And we also have recordings of structural competency webinars on police violence and decarceration, abolition of police, and redirection of those resources towards healthcare. So I invite all of you to join us in this effort to address structural racism and health inequalities at their roots in communities, institutions, and policies. Thank you.
Thank you so much, Dr. Hansen, for giving us the opportunity to learn about structural competency. We're truly lucky that we were able to learn about this from one of the leaders in the field. Now, just going forward, I'm going to share my screen and just talk a little bit about how we can incorporate some of those ideas into our curriculum.
So while you're doing that, I just want to say that I had the distinct pleasure of working with medical students at Toro School of Medicine, and you're going to be hearing much more about their work, but they actually were critical to launching the national network that I mentioned, Structural Competency Network, and the webinar series on COVID-19 and structural intervention. So it's a real pleasure to hear about your work.
Thank you. Yeah, so we're just going to be talking a little bit about how we were able to incorporate structural competency at our school, distinctly being an occupational medical school. And we'll talk a little bit about how that kind of comes into play. So just first off, my background, how I kind of got into this work. I studied public health and sociology at Brown, did my master's there as well. And I really learned a lot about structural violence and health equity, studied a lot of Dr. Paul Farmer's work, learned about liberation theology, and really became invested in kind of dedicating my work and my life to looking and achieving health equity. So we've had a few iterations of structural competency. Oh no, sorry, 1 second. Is it showing now?
Yes, that looks good.
Oh, it looks okay.
Yes.
Okay, sorry, my email popped up. Hopefully they'll cut this out, but I need to like get rid of this. Oh goodness, why is this happening?
Yeah, I just want to reassure you that we can only see your we can see your screen and it's perfect. So maybe your email, you can just minimize it because we're seeing the presentation.
Perfect. Okay, then I will just leave it alone and just let it be there. Okay. Sorry, 1 second. It's actually taking up like most of my screen, so I can't even see my slides. That's why I'm trying to exit out of it. Okay. There we go. Okay, yes, so we had several iterations of structural competency at Turo. First, we did a student-run structural competency lab. I was a student leader for this lab. We taught it for about 3 years, where we introduced students to the concept of structural competency with a didactic lecture first off, and then this was modeled off of the Bay Area Structural Competency Working Group, which is a small collective of multidisciplinary professionals, health professionals, and academics that teach structural competency to several institutions. So we had a didactic portion in our labs based off of their work. And then we would often lead our students through mind mapping exercises to discuss different ways that we can both screen for structural determinants of health, such as the health screener that Dr. Hansen mentioned that UCSF utilizes. So we use some examples of that, of what kind of screens we could incorporate into patient visits, and then also ways that we could connect patients to resources and develop our own structural humility as well. Then I was able to have the distinct pleasure of being accepted to the Primary Care Academic Teaching Fellowship, which is a unique position that we have available at our school for 4th years, where we can choose to split up our 4th year and teach semesters in the doctoring course, and then we propose a curriculum change. So as part of my curriculum proposal, I wanted to develop and implement a sustainable anti-bias, anti-racist curriculum, and a curriculum that would focus on other marginalized communities as well, such as the LGBTQIA community. As such, I designed a course that would touch upon these different areas and try to incorporate them. Given that the osteopathic principles of osteopathic medical schools stresses the connection between the mind, body, and spirit, and the interconnectedness of the human social condition and health, the faculty thought it'd be the most appropriate to incorporate this into our osteopathic course this past fall. And we actually just completed our structural competency module that was taught for the first time in this course. Going forward, we're looking for ways to incorporate this into the doctoring curriculum, basic sciences, and also reinforce these concepts in 3rd and 4th year as well. But I'll go into kind of what those plans are. So these 5 core competencies might look very familiar to you because Dr. Hansen just talked about them, but we definitely modeled our core competencies for the course based on the core competencies of structural competency. So that you've definitely just seen. And then the 3 main areas of the focus of the course that we taught were specifically on structural racism, LGBTQ health considerations, and then kind of using COVID-19 as a really great way of examining, the fractures in our social structures and using that as a case study to examine how vulnerable these different populations have been and how COVID has really revealed those vulnerabilities. We also went and actually reviewed some of the COVID-19 webinars that Structural Competency Working Group had presented this spring. So those were very helpful as well. So these were some of the key materials that we used, but this is not an exhaustive list whatsoever. And the course session components, there were about 6 sessions consisting about 2 hours each. Each course had a pre-class reading and our videos to watch, and then we'd start with a discussion regarding the readings or videos. We would always have a speaker presentation or a panel discussion. Like for the LGBTQIA sessions, we had both LGBTQIA physicians and also patients offering different perspectives on healthcare. And then we also had case-based discussions. So for future plans, we have many since this has just started. First is that we would like to create a marginalized community health considerations curriculum subcommittee of our curriculum committee. And that's a mouthful, but basically the purpose of this committee would to make sure that this is continued and sustainable efforts, not just based on student efforts, but that this is actually a main focus of our school going forward, and that our school is able to use this committee to hold them accountable to continue providing curriculum of this sort. So, so far we're creating the curriculum right now. I'm going to be on it as a primary care fellow and also as a representative of our chapter of White Coats for Black Lives. We also have invited leaders from the Latino Medical Students Association to join, the Black Students Association, the Rainbow Health Coalition, which is our LGBTQIA associated organization, and also our diversity inclusion chairs. And so, and as well as the faculty department heads of the different courses. So the goal of this curriculum committee is to create a reporting system for any discrepancies in curriculums as it is currently. So if there's anything that students are triggered by that they find to be problematic, for us to have a centralized way of addressing those concerns. We have goals of assigning summer reading, so hopefully we'll get medical apartheid to be approved as our mandatory summer reading for all incoming students next year. We're also going to be evaluating our pre-clinical curriculum, which is a systems-based curriculum that goes through cardiovascular system, then respiratory, renal, etc. And we're going to be evaluating how we can include considerations of marginalized populations in all of those systems. Including but not limited to discrepancies in Black maternal mortality, eliminating race-based calculations in GFR and the renal unit, discussing LGBTQIA and racial health disparities in psychiatry and mental illness, particularly due to minority stress, and similar topics. And we're also working, I'm part of a steering committee to have structural competency incorporated into our official mission statement, and therefore that will guide further development and program learning outcomes to hold our university accountable for providing this kind of curriculum. Because one thing that has happened from a lot of the changes that universities have been trying to bring about in regards to this is that a lot of student efforts have been really great and robust, but we do need to figure out ways that we can make this sustainable so that it's not just students providing these kinds of changes. So yeah, those are kind of our next steps. We're also going to just be assessing any outcomes and feedback from the program that we've rolled out so far. And then hoping to standardize a curriculum that can be easily translated into other settings. So now I just kind of wanted to talk a little bit with Dr. Hansen and see, if we could talk about any tips that she might have for bringing this about to other universities.
Thank you. Well, actually, I'm learning from you, and I would love to ask you a question or two.
Sure.
So I'm just looking at the time. Do you know how much longer we have for this session?
Yes, we've got about 7 minutes.
Oh, great. Okay. So one thing that's so striking about what you just described, Jessica, is it's so comprehensive, and you make it sound so easy, so seamless. My guess is that it's not that easy, actually. And I wonder if you could share with us a couple of moments, like what are the moments where the idea of structure as a driver of health and the role of the clinician seem to kind of click for people involved in the structural competency curriculum? Were there some case examples or readings or discussions where the light bulbs seem to go on? I just want your thoughts about that. And
Sure.
I recognize too that this might be a group of people that already are thinking a little bit more holistically about health because they chose osteopathic medicine. But I can imagine that not everyone comes to the table with the same understanding about structure and health. And then on the flip side, what have been some of the struggles, things that you might still be grappling with?
Thank you. Yeah, that's a great question. So for some of those light bulb moments, I think that in a way, students were more receptive to this curriculum this year than I've seen in the past as a leader of structural competency labs at our school in the past. I found there to be more assistance, but I think the fact that we taught this from the get-go, it started as soon as school started for the first years. And it was following a very tumultuous summer where I think people were at home and really tuned into the current events in the country. I think in a way, and as unfortunate as it is, as the events were, I think it made students a lot more receptive to learning and more interested in learning about this. And I think they were really excited by the fact that we were offering this curriculum right from the beginning.
Mm-hmm.
And I think that
it seemed relevant to their everyday lives in a way that it maybe hadn't been before
exactly.
COVID-19, Black Lives Matter, kind of
Right.
political upheaval, especially around health. Yeah.
Right. And I think COVID-19 really blew the lid on this entire, on all of this. And so I think in a way that has been like a positive side effect of this all. I think we do still struggle with some things. I think when people are confronting their privileges, it's very common to get defensive. We've had some papers by key sociologists talking kind of about how like white power structures in medicine and in healthcare particularly endanger patients, and we had many white students become very defensive about such topics. And so I think those conversations are always going to be a little bit delicate and difficult ones, but I think overall students have been receptive. So it's been overall pretty positive.
Oh, that's really observant and helpful. Do you have to remember the name of the sociologist writing about white privilege?
I for some reason cannot remember off the top of my head.
No worries. I'm just imagining because that is something that has come up repeatedly, right? That somehow some students feel that they're giving up something by acknowledging structural drivers of all sorts of things, including health. Because in our society, we like to believe that what we have as a result of our individual merit and grit, right?
Right.
So in a way, people who are high achieving and make it to medical school, they like to hold on to that feeling that they worked really hard to get to where they are and deserve it. And, you know, when confronted with information about all these hidden structures that also help to support and propel them forward, it seems as though it's somehow taking away. Do you have any sense of how students who are able to reconcile those things do reconcile them in their own minds?
I think most of the ones who most easily do so have kind of come to understand that already. They may not know everything about structural competency, especially the language. A lot of the language in a lot of the texts that we use come from sociology and other academic forms that people might not have been exposed to, but they're comfortable with the idea of white privilege, at least, and things like that. So I think the people who have come to terms with it already kind of had heard of it, but I definitely see some people's eyes opening up, even faculty, and it's really interesting to just like have those conversations and see that change. So,
is there anything that people feel that they gain once they take that perspective, that they're looking for structural explanations instead of individual ones? Anything that they get from it professionally or personally?
Yeah, I think that they gain somewhat a sense of responsibility or a inspiration to try to do something about it, which is really positive to see. But that actually brings me into a question I have for you.
Yeah.
Which is, when we're examining structures as large as products of colonialization, redlining practices, downstream effects from slavery, these are really large and heavy topics. And sometimes when we're talking about these, especially to students and people, it's very easy to just feel like, well, what can we do about it?
Right.
So how do you, I know you kind of touched upon this earlier, that our role is in advocacy and whatnot, but what is your advice for medical students who might feel like this is all very daunting?
That's such a great question. And I have colleagues, again, at UCSF who have been studying the impact of teaching what they call social determinants of health. I think they include structural drivers in there. The impact of teaching about that in the classroom versus teaching about that and then pairing it with some concrete actions that trainees can take. And they're finding that if you do not pair that teaching, the background of colonialism and structural racism and all of the things that are so embedded in our society that drive health outcomes, if you teach that without pairing it with actionable items, people actually come out more disillusioned, paralyzed, reporting early symptoms of burnout, if not more advanced symptoms of burnout. But giving people concrete steps is what leaves them feeling more empowered. And you mentioned that yourself. I come from psychiatry, especially a specialty where burnout is particularly prominent right now. And a lot of that has to do with seeing, even as early as internship, people cycle in and out of the ER, in and out of inpatient hospitalizations, and really not having any success with recovery outside of treatment settings. And so it's actually, I like to make the pitch to my clinical colleagues, it's for our own survival that we have to look for structural actions that we can take on behalf of our patients. That's the only way that we're going to get substantial professional satisfaction in our work and a sense of purpose. Because most of us chose this route because we actually wanted to think of ourselves as doing good for other people. But if you work in the status quo medical system for long enough, you lose that compass, because we really don't have a functioning healthcare system. And it does end up feeling very punishing, not only to work inside of it, but to be a patient in it. So we have to take action towards small steps, small local actions towards systemic change for our own survival as clinical practitioners. That becomes what sustains us. And I think one reason why organizations that are coming together for trainees around structural competency or health justice or any other term that you want to call it, why they're so vibrant and they're growing so quickly, is that people not only get a sense of purpose and a sense of empowerment, that once they understand the true fundamental causes of their patients' health outcomes and understand what kinds of actions they can take towards them, they can do something meaningful. But they also really get a lot from the collective spirit, that there is this up and coming generation of medical students, residents, and trainees that are putting together different levels of analysis. So that even though senior faculty, for the most part, lack that kind of orientation, I'd say there's a big generation shift with many of the people at medical schools across the country who are leading the efforts around all sorts of health justice, including structural competency efforts, being young people and starting as students and starting as residents, and senior faculty often resisting and being very confused by things that they were taught don't belong in medicine, right? Because the medicine is about the individual and the individual's behaviors. It's not, and their biological predispositions. It's not about community conditions and schools or urban planning or public policy. It's really the younger generation, your generation, that's taking this up and being energized by it. So putting these kinds of levels of analysis together provides a roadmap out of what is really kind of a mess. As I mentioned, the US of all industrialized nations has the worst health outcomes and spends the most money on healthcare. So there's something really not working well, but there is something that we can do collectively, not as individuals, but if we collectively, all of us being trained in this era of COVID, inequalities, of Black Lives Matter, and having much more of this material presented to us, if we can come together, we can reorient medical practice.
Great. Thank you so much. That gives me a lot of hope.
Oh, you give me hope. You're doing fantastic work at Toro.
Oh, thank you so much. And thank you for leading the way. I mean, I remember first reading, that article that you wrote with Dr. Metzel, and I was
Thanks for saying that. Do we have time for one more question from me to you?
Yeah.
Unfortunately, we are over the half hour, but let's continue the conversation. Let's go for it.
Oh, okay. Well, my question had to do with, I really liked your focus on LGBTQ health. So I wondered how, in your experience, that has mapped on, like a structural analysis of LGBT and action around LGBTQ health. How has that mapped onto other kinds of structural problems, like structural racism, in your curriculum and with your medical students?
Sure. So obviously all these identities are intersectional. There are queer Black people. And so because of that, we have tried to focus on, how all of these identities can affect access. So we've talked about how trans people are more likely to experience homelessness, be denied jobs, anything from that to the fact that they have really a lot of difficulty accessing health due to just a lack of knowledge of how to treat trans patients. I think there's a statistic of nearly 3/4 of respondents in a survey said that they had to teach their doctors something about trans health. And that, the burden should not be on patients like that. And so that's something that we've tried to delve into, is just being competent in providing care to LGBTQ people. And that first, starts with dispelling any myths about those populations, and just including also gender inclusive language, teaching about pronouns, and getting people kind of acquainted with all of that kind of language first, so that at least if, they may not know, a physician who sees a patient may not know the specifics about hormone therapy or some things like that. But if they, in just their basic interactions, if a patient comes in with a cold or anything like that, if they can just do small things like be gender affirming in their language, that can go a long way and help rebuild trust in the medical system as well. So that's been kind of our focus, just starting from the basics with all of that, because we don't have really any mention of that in our curriculum. formally until now. And that's something that's really important. A lot of medical students have said themselves that they don't feel like they're competent in this area. So that's kind of something that we've tacked on as well.
That's exciting. I mean, for myself, having gotten my start in AIDS activism decades ago and seeing what you're talking about, the intersection of race, class, gender, identity, sexual orientation, all of those things, they have a similar trajectory, right? They overlap, they reinforce each other. And really this is about addressing the health impact of hierarchies and power inequalities.
Exactly.
So it's exciting to see the work you're doing. Thank you, Jessica.
Thank you so much. I'm always just in awe of all of you guys who are inspiration.
Likewise. Great. Well, so hopefully, Sarah, is this